All right, let's talk about a topic you are absolutely 100% guaranteed to see on the NCLEX and in your clinicals, laxatives. In this quick guide, we're going to break down everything you need to know, the high-yield facts that will help you ace those questions and keep your patients safe.
So, here's our roadmap. First, we'll nail down the actual problem we're trying to solve. Then, we'll dive into the different kinds of laxatives, from the gentle starters to, well, the real powerhouses. And we'll finish with what is arguably the most important part, your nursing safety checklist.
So let's set the scene. You're on the floor, you're looking at your patient's chart, and you see it right there. No bowel movement in 3 days. This happens all the time, right? But what you do next is absolutely critical. And spoiler alert, the first step is not reaching for a laxative. It's all about assessment. So what is constipation really? Yeah, the textbook will tell you it's fewer than 3 bowel movements a week. But you know and I know it's so much more than just a number. It's about what the stool is like. Is it hard? Dry? A real struggle to pass? And you gotta listen to your patient. When they tell you they feel like they just can't get it all out, that's a huge piece of the diagnostic puzzle.
Okay, time to be a detective. Seriously. Before you even think about giving a laxative, you have to figure out why this is happening. Is your patient on opioids? We all know what those do. Or maybe iron supplements. Are they dehydrated? Or maybe they're just not moving around much after surgery. Getting to the root cause is absolutely everything. All right, so let's say we've done our homework and a laxative is the right call. Where do we begin? You always start with the gentle options. Think of these as your first line of defense. These two work in completely different ways. On one side, you've got your fiber supplements, like psyllium. Think of it like a sponge. It soaks up water in the gut and makes the stool bigger and easier to pass. Now, here's the huge can't-miss safety warning. Your patient has to drink a ton of water with it. If they don't, that sponge can turn into a brick and cause a blockage. No joke. Then you have stool softeners, like DocuSate. This one's different. It's more like a detergent. It just helps water mix into the stool, making it softer. And notice, neither one of these is a quick fix. Okay, let's level up. Now we're talking about solutions that really bring in the water, but in a much more direct way, osmotics and lubricants.
I love how this works. Osmotics are basically just water magnets. So your patient takes something like milk of magnesia. It gets down into the colon, and then whoosh! It just starts pulling water from the surrounding tissues right into the bowel. It's like flooding the zone. All that extra water softens things up, adds some bulk, and that gets things moving. But wait, this is a huge NCLEX right flag right here. When you pull all that water, guess what comes with it? Electrolytes. This is a big deal. You can throw your patient into a serious electrolyte imbalance. That's why you have to be super cautious giving these to patients with kidney disease or heart failure. Their bodies just can't handle those massive fluid shifts. So important to remember. And then there are the lubricants, like a mineral oil enema. It's exactly what it sounds like. It's like greasing a water slide. It just coats everything to make it slippery and easy to pass. And look how fast it works. We're talking minutes. This is for when you need a fast result. But the catch is that oily coating can also block the absorption of other medications. So as the nurse, you have to be super smart about timing.
Okay, big shift here. Everything we've talked about so far has been about changing the stool itself, bulking it, softening it, lubricating it. Now we're talking about drugs that work on the bowel muscle. These are the heavy hitters, the stimulants. I call them the movers because that's exactly what they do.
Let's look at the two big ones here. You've got bisacodyl, which basically annoys the colon into action. It stimulates the nerves and forces those contractions, peristalsis. It's fast, but it can definitely cause some major cramping. Then there's senna. Now, the huge warning with these stimulants, especially for the NCLEX, is the risk of dependence. If someone overuses them, their bowel can get, well, lazy. It literally forgets how to work on its own, and that's a huge problem.
Okay, we've gone through all the drugs, but honestly, none of that matters if you don't get this next part right. This is the most important part of this entire discussion, your nursing safety checklist. Listen up. This is rule number 1. It is the absolute non-negotiable first thing you do. Before you even think about giving a laxative, you must rule out a bowel obstruction. Just picture it. There's a total roadblock in the gut, and you give a drug that's like hitting the gas pedal. You're just ramming everything into a wall. You could cause a perforation. It is an absolute contraindication. So what does that actually mean for you at the bedside? It means you're putting your hands on the patient's belly. Is it hard? Distended? Painful?
You're putting your stethoscope on and listening for bowel sounds. And you're documenting that last BM like it's the most important piece of data you have. Because it is. And always remember, meds are not the first choice. Our first job as nurses is to push the basics, more fiber, more water, and get that patient moving. Phew, that was a ton of high-yield information. You've got the mechanisms, you've got the safety alerts. Now, the only way to really make this stick for your exams is to put it into practice. So, think you've got it down? The best way to find out is to test yourself. Head on over to my website, nursingwithcharity.com.ng, and try out some practice questions that are just like what you'll see on the NCLEX. Go prove you know this stuff cold. See you there.